Hello, I'm Dr. Beth Goethe.
And I'm Dr. Martha Leatherman. I'm a geriatric specialist in psychiatry.
And I'm a neuropsychologist, and I specialize in aging.
We're experts in dementia care, and we're here to provide you some information and answer some questions that we hear very commonly about dementia and other issues in aging.
Hi, well, I have a really important question to ask you. We do know that in some patients with dementia, with Alzheimer's, other types of dementia, that there can be psychotic or severely depressed kind of behaviors, hallucinations, suicidal thinking, aggressive behavior, combative behavior, delusions, thinking that something's happening when it's not, getting really paranoid. What kinds of things can be done for those patients? What can happen in the medical community for those kinds of problems?
And I think maybe you're talking about the question of inpatient hospitalization. When is, and I've heard it termed many things, I'm not being insensitive, but lock up or intensive psychiatric care, different things. When is that appropriate? And I'd have to say, first of all, from state to state, it's different, depending on the laws for how you can get somebody into the hospital. And so I'm not going to go into that. It's very complicated. I think the important thing to question is, what are you going to get out of it? No matter where you are, what state you're in, Medicare usually covers only very short duration hospitalization for urgent stabilization. And usually that's done with a lot of medications. Because I've had patients and families say, she had a really bad childhood. I think if she could spend 2 or 3 weeks processing that in the hospital, it would be easier to take care of her at home.
No.
Not going to happen in the hospital. It is for short-term, acute stabilization. The other thing that tends to be the case, and this is not at every hospital, but you need to think about it, is that the coordination with the psychiatric service and the medical service is typically not very good. So if you're wanting somebody to go in for a full evaluation and make sure there's nothing medical causing the problem, nothing psychiatric causing the problem, looking at the whole thing, that's going to be pretty fragmented. Most psychiatric facilities will not admit somebody who they consider medically unstable. So if they have
medically unstable would mean
uncontrolled diabetes, active chest pain, a lot of medical problems, an infection. Somebody has to be very physically healthy usually to be admitted to the inpatient psychiatric unit. And there's an internist usually that comes in and sees them while they're there, but that's not the place for treatment of a complicated psychiatric medical condition.
A lot of times what happens in facilities, assisted living or in nursing facilities, there will be behavior changes and what will happen is, because those behaviors are so uncontrollable for the staff to manage, frequently, all too frequently actually, but frequently, the person will be transferred and admitted into an inpatient geriatric psychiatric unit, treated briefly, then sent back to the nursing home or assisted living on a lot of medications. And they're kept on those medications, but getting them into the psychiatric hospital, the psychiatric unit, is sort of the basic thing that people will do.
Yeah, it tends to be a first reflex is, well, let's get them in the psych unit. And the psych unit is really not designed for anything except acute stabilization, which again is all of these medications. So the important thing is to think about all of the things that we've talked about before, what in the environment might be triggering behaviors? Is this something we can manage without a lot of medications? Is somebody actively trying to hurt somebody else or themselves? Now, that's a very good indication for going inpatient, is active suicidal or homicidal thinking or plans. But behavior changes are rarely well managed inpatient. Because as soon as you're discharged, you're back to the other environment, and you've still got to adjust the environment. Or if you're adjusting medications, you've got to adjust the medications to the environment.
Right.
It's a lot more complex than just kind of going in to get fixed.
Right.
Doesn't really happen.
And what I've noticed about the geriatric inpatient units is when they're really helpful, when a person is homicidal, aggressive, or suicidal, or care is so difficult to provide because of their hallucinations or paranoia, and you need to get them into a situation where there's psychiatric nursing, psychiatrists and staff who are aware of what's going on to stabilize them and monitor those medications. That's when it can be really helpful. But all too often people try to just, well, let's ship them to the psychiatric unit and they'll fix them, and then when they come back they'll be okay, which is not the purpose of those units.
No, and it doesn't work reliably. So the principles kind of remain the same. You need to find a physician that you have a relationship that you can work with. And you need to always work around environment. You need to always look at the basics of, is this an infection? Is there something else going on driving this behavior? What can we do as an outpatient, which is slower? But ultimately people tend to get better, more reliably, and with fewer medication side effects if you can do it a little bit more graded. Again, the psychiatric hospitals are useful in their place, but not a fix-all.
Right.
For more answers to questions like these, our book, The Insider's Guide to Dementia Care, is available at Amazon.com.